Welcome to this video of anterior segment examination on a slit lamp. Here we're going to show you a patient who is post Ahmed glaucoma valve surgery. Here you can see this is the AGV valve which is visible over here, the tube which is coming into the anterior chamber. This is the front part of the tube, and we'll show you all parts of the tube going through the video. What you want to see, the anterior chamber is deep and is well formed, and the tube is present. What you're seeing here is the patient was a pseudophakic patient. Then we go backwards and see where actually the tube is coming from all the way. The pupil is slightly oval or irregular. Then we go on to diffuse examination in lower light to see the Ahmed glaucoma valve, which is placed around 8 millimeters from the limbus. The tube is about projecting. So this, if we trace the tube over here, we can see the tube is going over here. It is, what I've done is made a tunnel from this area. So there is a tunnel from going from this area to this area in the sclera through which the tube has been passed. This is the area of the tube which is present in the beneath the subtenon space, and this is the valve actually which is present. And this area is about 8 millimeters from the limbus and on this area. So this is the AGV. Then you can see scattered subconjunctival hemorrhage. Then these are congestion of blood vessels in this patient. But this area, you see an elevated area, and when actually you're putting this tube in, it's usually very important and sometimes very difficult to get that place in the right area. In this area, you can see these are the anterior ciliary blood vessels which are coming over here. If I clear this area, it's important to find out that these are the anterior ciliary blood vessels coming from the superior rectus, and here you will see anterior ciliary blood vessels coming from the lateral rectus. It's very important to place the valve between these blood vessels, because if these valve is placed on these blood vessels, I've seen patients who get erosion of these blood vessels and bleeding or a hemorrhage in this area. So let's go forward and keep looking at this thing. Clear this, and we come back and look at, and this area has been sutures with 10-0. These are the two sutures which you saw where with the valve has been sutured, the plate has been. Now we're going to go on the posterior segment and look what pathology the patient had. So here you can see the patient has a pale disc and his cup to disc ratio is about 1. So it's pale disc, his nasalization of blood vessels. Then you will see PRP marks over here, patients with diabetes and extensive diabetic retinopathy which has been treated. So his patient, most probably, I think preoperatively, I had given him intravitreal Avastin to control his proliferation of new vessels on the iris as well. So this is a patient with NVI producing secondary glaucoma or neovascular glaucoma, which you're seeing, which has been treated with an AGV valve. The disc is more apparent over here, and here you can see, probably you might think this is the cup, but what you want to see where the blood vessels are turning outward. So this is the area where the actual cup is, and so this seems to be a cupping of 1 in this patient. Then going above and below, you will see PRP marks. The macula seems to be all right in this patient. But you have to be meticulous to see area of PRP. Here you can see PRP marks in this area, and there seems to be some epiretinal fibrosis in this area as well. So going through all the retina, you need to see in all quadrants how much area there is, and if there's any deficient area of PRP, you will need to do an enhancement of PRP in this patient. But luckily, it had got a very good PRP laser done, and then you're checking for the intraocular pressure. And the important thing when you're checking for intraocular pressure, you look at the Myers. So you see the Myers are touching, and the Myers should, these are the Myers which are touching, and they should be touching inside out like this. If the Myers were not like this, and when you started off the Myers were like this, they were far apart, that means that the pressure is high. But if the Myers were like this, that they were overlapping too much, that means the pressure which is recording is too low and you need to raise your reading. So this patient had an intraocular pressure of 16 post AGV valve, which was pretty satisfactory for this patient. So you just need to touch those wires. Sometimes people, what they do is, if this is the tonometer, they would go in, and if you're looking from the side, it should just touch the cornea. It should not indent the cornea. Some people like to just push that area into that, and you will see when, if the tonometer is like this, it tends to push backwards when it touches the cornea and applanates the cornea. So actually, when the applanation tonometer is over here, and if it is on that stick, if it touches the cornea, it should not move. It should stay stable in that area or just slightly move backward. So that is another step which you should also know with tonometry. This is Goldman applanation tonometer using the Hochstreit set time, which we're using. And this is an interesting case which you see pretty, not very commonly, but if you see, you should be able to recognize these findings. Thank you very much for watching.